as a representative of the Fetal Medicine Foundation, I used to be a fellow at King's College Hospital. So I did a 2 years fellowship with Professor Nicolaides, and I'm very happy to present you let's say a new marker in prediction of preeclampsia, so the ophthalmic artery Dopplere in risk assessment for preeclampsia. So first, let's go back to what is already established throughout the world. So screening for preeclampsia based on the risk scoring system, very, very similar in England, in the United States. We know that it's ineffective. It was proved in the SPREE study in England when there was a head-on comparison in a series of hospitals in the UK that the NICE guidelines versus the competing risk model proposed by the Fetal Medicine Foundation. And then it was implemented in combination of maternal factors with PLGF, mean arterial pressure, and uterine artery Doppler at 12 weeks. And there was exactly a doubling in the detection rate with this new approach. So in the last decade, a series of biomarkers were examined mainly by the Fetal Medicine Foundation, and now we can summarize that we have essentially 4 at different stages of pregnancy. So at 12 weeks, we have mean arterial pressure, uterine artery Doppler, and placental growth factor, also PAP-A, but only if we do not use PLGF. At 22 weeks, we now also include FLEET, and the same is true in the 3rd trimester. And we move on to the end of the 3rd trimester, and the uterine artery Doppler is not useful. And we have the triple tests, so the mean arterial pressure, placental growth factor, and FLEET. So now, what is ophthalmic artery? Ophthalmic artery is the first branch of the internal carotid artery, and then it has a series of other branches that go to the nose, to lacrimal duct, to ciliary duct, to ethmoidal bone, and to retina. It is embryologically, anatomically, and functionally similar with the intracranial vasculature, and in this respect, it provides an easily accessible method of assessing the intracranial circulation. We have also known from the 1990s that in pregnancies with preeclampsia, clinical evidence of preeclampsia, there is a decrease in the pulsatility index and increase in velocity. So there is vasodilatation in these vessels. An important name in this respect from the fetal medicine is Professor Belfort from Texas, who in 1999 wrote a paper on this very topic, and that in women with established preeclampsia, there is dilatation of the vessel and there is decrease in the resistance to flow in this vessel. So in preeclampsia, there is alteration in the flow in this vessel. So how we do this measurement? The measurement takes maximum of 1 minute. You use the same machine as usual, but you need a linear probe. So you put gel, you ask the patient, ask the woman to lay down, she closes her eyes, and you gently put the transducer over her eye. And then when you put the transducer, you can see here the video, and you see a translucent optical nerve, and then medial to that nerve is the ophthalmic artery. And there are not many vessels to confuse it with. And this is the type of waveform that we get. So this is the type of waveform that we get. And here you can see also the standards that you have to use for getting the waveform. They are clearly defined. So these are the standards. So let's now look at the waveform. So in the waveform, there are 2 peaks in systole, first and second, and then there is end of diastole. And then we have 3 specific studies, all from Brazil, on the use of this technology for the prediction of preeclampsia. A very small study in a very high-risk population where the incidence of preeclampsia was 7%. Normally, it's about 2 to 3%. And in this study, they showed that this systolic velocity, so that second wave, not the first, not the pulsatility index, the second waveform, was increased, and it added marginally to the detection of screening for preeclampsia with maternal factors alone. And then we have the study in the second trimester, defined as 20 to 28 weeks, less than 350 pregnancy, high-risk population, also from Brazil, and it suggested that ophthalmic artery is as good in the second trimester as the uterine artery Doppler, with the detection rate of 75%, with a false positive rate of 25%. And then the first group did another study themselves in the second trimester at 18 to 23 weeks, again, a small number and a very high-risk group for preeclampsia, and they showed there was no significant difference in any of the indices from the ophthalmic artery between those that developed preeclampsia and those that did not. So the Fetal Medicine Foundation investigated further the ophthalmic artery as a potential biomarker of preeclampsia. So the first study investigated whether ophthalmic artery is useful at 38 to 37 weeks. All women that agreed to participate in the study were routinely examined at the time of the routine 36 scan. Various indices were measured, and it was found that the only one that was useful in the prediction of preeclampsia was the ratio of the second to the first systolic peak velocity. Not the first, not the second, not the pulsatility index, the ratio of the two. So indices were measured 4 times, the left eye, the right eye, then again the left eye and the right eye, in a very similar way that we measure the mean arterial pressure. And it was found that within the same eye, the first and the second measurement were well correlated. The correlation, however, between the measurements between the two eyes were less well characterized. So the statistical analysis showed that by taking the average of the 4 measurements, the performance reaches about 100%. If we take the average of the 2 from each eye, the performance is also good, it's about 98%. But if we only measure one eye, there is a drop to about 90%. So the conclusion was that, firstly, ophthalmic artery screening as a mechanism is useful, but you need to take a minimum 1 measurement from each eye and then take the average of the 2. And number 2, the only index that is useful is the ratio of the second to the first systolic velocity. And now looking at the performance of screening, so the red dots here are from women that subsequently developed preeclampsia, and the blue line here is from those that did not. And you can see that the earlier you develop preeclampsia from the moment of the assessment, the greater is the value of these velocities. So if we compare the detection rate of preeclampsia within the subsequent 3 weeks by maternal factors alone, it is about 30%. And it jumped to nearly 70% by adding the ophthalmic artery. And if we look at any type of preeclampsia, again, we had a major improvement in the performance. We know that useful biomarkers in the 3rd trimester are mean arterial pressure, also addition of placental growth factor and fit. It was found that ophthalmic artery, so the red histograms compared to the blue, was improving the performance achieved by the combination of maternal factors and mean arterial pressure, but it did not improve it further what was achieved by the addition of PLGF and fit. Also, we also had an improvement for the prediction of any preeclampsia. So the study proved that ophthalmic artery is a good biomarker for preeclampsia at the end of the 3rd trimester. And it was also examined in the 3rd and in the 1st and 2nd trimester, and it showed that it's also a useful biomarker, especially for the earlier type of the disease. So now, in summary, we can say that we have the biochemical, biophysical biomarkers of preeclampsia, and among the biophysical markers, we have also ophthalmic artery second to first peak systolic velocity in the 12 weeks, 22 weeks, and 36 weeks scan. So thank you very much for your attention.